Thanks very much. And first of all, thank you very much, Rasha and Merck and UNESCO for inviting me to come and give you some reflections. I think, Rose, you said you were between people and lunch. I've got a much more difficult job because I'm between people and their posters, which is a much more engaging, exciting part than lunch. So I thought I would give a few reflections on what's been happening with the HIV/AIDS epidemic and how African science and policy and community have really been key to really quite an optimistic story about the way that we've been going and to learn some lessons out of that. It's easy coming at the end of the talk of the day's proceedings because quite a lot of the things that I want to say have already been said by other people, and I'd like to, where I can, expand on them and build on them. Central to this is the notion that if we want to make progress, science and research are not enough, that we need to involve policy and policy makers throughout, that we need to involve community and community members throughout in order to have that tripod. It seems that today is the day of Nobel laureates. And last week I was in Paris for Françoise Barré-Sinoussy's celebration of her retirement from her laboratory. She discovered the HIV virus along with co-workers and others and won the Nobel Prize for that. It was 1984. Here's her picture of the first HIV viruses grown in culture. That was just at the time that I was qualifying in medicine, so my life has also, since we're a rather biographical set of speakers, has also been exposed to a lot of HIV work over the years, first in clinical care in London, subsequently in Zambia, and subsequently back in Geneva. Françoise Barré-Sinoussi is interesting because in 1985, she moved, having been entirely a laboratory scientist in France, and she moved and started doing a lot of work with Africa. In 1985, she was part of the first WHO mission to define a clinical definition of AIDS in Africa, the meeting in Bangui in the Central African Republic, for which she was the rapporteur. And ever since then, she's been strongly committed to moving science to particularly Francophone Africa and building research capacity with ANRS, particularly in West Africa. So I moved to Zambia in the early 90s, and it's nice to come just after Andrew talking about the situation for HIV before antiretrovirals. Those of us who have grey hair or no hair remember a very difficult time for working with HIV. So Catherine Nirenda and Winston Zulu were the first woman and the first man in Zambia to be publicly open about their HIV positive status. Sadly, they both passed away. They both got onto antiretrovirals. Catherine died as a result of domestic violence and nothing to do with HIV, which is also something about the context in which people live despite HIV. And Winston Zulu, who was a passionate TB and HIV advocate, died of resistant HIV, having been lured into the anti-science driven by President Mbeki and the HIV denialists, which of course also had Nobel laureates amongst their protagonists. So remember that not all Nobel laureates continue to get it right forever. Both Catherine and Winston were part of the first trials of isoniazid preventive therapy in Zambia long before antiretrovirals were available. And it makes me always think about the cascade. In HIV, we often talk about the treatment cascade, from diagnosis to treatment to viral suppression, and that forms the basis of UNAIDS 1990 agenda. But we also, as I think mentioned by Andrew, have the cascade of policy, from a question to the evidence to recommendation to policy, and hopefully then on to practice and impact. But we know that too often policies languish, so that the policy on isoniazid preventive therapy, which was produced in 1998, is still not very widely implemented in many countries, despite the clear evidence that this is a way to prevent tuberculosis in people living with HIV. So in those times in the 1990s, it was extraordinary, really, that when the Millennium Development Goals came out in 2000, that the target for Millennium Development Goal 6 was to halt and to begin to reverse by 2015 the spread of HIV. And many of us in the field thought that this was hugely optimistic and unlikely to ever be achieved. And yet, as we all know, there's been extraordinary progress in the HIV epidemic, and we've smashed the MDG target, if you like. You can see that we've clearly halted and reversed the spread of HIV. 30 million infections have been averted, including 1.4 million children, and the number of new infections is falling. Still 2 million new infections per year, so let's not congratulate ourselves too much, but we've clearly turned a corner. Similarly, for deaths, nearly 8 million deaths have been averted during the Millennium Development Goal period through the scale-up of antiretroviral treatment. And another target which we had, which was to reach 15 million people on antiretrovirals by the year 2015, has already been met. Most extraordinary. Many people, when that target came out, said there's no way you'll get 15 million people to take antiretrovirals every day in order to challenge HIV, and yet we've already done that. So a massive sense of achievement. And I want just to reflect briefly then on some of the science that's led into that. I don't have to go over Pontiano's slide again, because this is the slide that he showed from the MRC, showing the rise in life expectancy that antiretrovirals have brought in rural Uganda. There's a similar slide from the Africa Center in rural KwaZulu-Natal. So I'm highlighting the role of the big, long-standing demographic research projects in various parts of southern, east, central, and indeed West Africa that have contributed to our understanding of what can be achieved with antiretrovirals in turning life expectancy around. And the World Bank has recently, or not so recently now, but these are data from the World Bank, showing that the southern African countries with life expectancy dramatically falling and dramatically improving. HIV is exceptional. There are no other conditions that have changed life expectancy on this scale that we've been witness to in any of our lifetimes. When they publish the global burden of diseases, they always have to abbreviate the changes in HIV because they would go right off the top of the scale on the bit of paper and the journal wouldn't be able to print them. So HIV is an extraordinary and exceptional condition. It's not only death from HIV that's fallen, we've seen tuberculosis falling promptly, and perhaps most excitingly, we've seen the impact that scaling up antiretroviral may be having on the transmission of HIV. So this is very interesting and exciting work from the Africa Center that I hope some of you are aware of, but it combines various nice aspects of science that's being done. This is the geographical area in which the Africa Center has its base. And these are time series showing in these examples the HIV prevalence, which started off low at less than 10% and gradually became worse and worse until there were areas of the country, of the sub-district, where the HIV prevalence was more than 40%. And then here is looking at the coverage of antiretroviral treatment in the same period, being scaled up as we go to the proportion of the population taking antiretrovirals. And what they showed was that if you lived within 3, and you took the people within 3 kilometers of you, and you looked what proportion of them were taking antiretrovirals, the higher the proportion of people taking antiretrovirals around you, the lower your HIV incidence. And so this is ecological, but it's the first strong evidence at a population level that scaling up antiretrovirals really may be having an impact on the epidemiology of HIV. It's not completely straightforward. This is another study, again from an African cohort in Mombasa, of female sex workers in Mombasa. The black dots show the incidence from a horrendous 11 or 12% in 1998, falling gradually over time. And in red is the population, the overall population HIV prevalence, which is falling, and in green, the proportion of that population that is on antiretrovirals. And so you can see that as the proportion of people taking antiretrovirals grows, so the number of new cases in the sex workers falls. But of course, you can also see that it was falling quite sharply before any antiretrovirals were given. So we shouldn't exaggerate the notion that the reason that HIV incidence is coming down is only because of antiretrovirals. And for that reason, there are large ongoing community randomized studies, of which the largest is the POP-ART study in Zambia and South Africa, where 1 million people in 21 communities are being randomly allocated to different interventions, and at the community level, the HIV incidence is being measured in order to see what's being achieved. And I'd like to re-emphasize, which again various people have done, the importance of collaboration and of networks for big science. If you want to answer big, important questions like whether or not antiretrovirals really can change the epidemiology of HIV, don't do it on your own in a little clinic somewhere. Form part of a collaborative network, build collaborations, because it takes big networks to answer big questions, and that's something that's come out once or twice in what we've seen. So in POP-ART, the population effects of antiretrovirals, they're basically going door to door to households with community-based workers who they call CHIPs, who are community HIV intervention practitioners or something like that. So a community health worker goes door to door, encouraging people, not forcing them, but encouraging people to undergo HIV testing. And those people who test negative are referred, the men are referred on for circumcision and for other forms of prevention, and the positives are referred through to get treatment with antiretrovirals, and the different arms have slightly different arrangements of those packages to be able to tell over the next years what the impact at a community level, not at the individual level, but at a community level, the impact of antiretrovirals is. Antiretrovirals have also been shown to be useful directly in preventing HIV when used by people who are HIV negative. So the first study, again from Africa, from Durban, from the Caprisa group in KwaZulu-Natal, showed that tenofovir gel could be used to prevent HIV. Sadly, a much larger follow-up study, the FACT study across southern Africa, has failed to replicate this because of the challenges of adherence, that women don't always use this gel, and there are still, therefore, questions about how we might take this sort of work forward on microbicides. But subsequently, oral antiretrovirals given as pre-exposure prophylaxis, so being given to people who are HIV negative but at substantial risk of acquiring HIV, in this example because they were living in a discordant couple where one partner was positive and one partner was negative. And when the negative person is given antiretrovirals in couples in Kenya and Uganda, in a very big study of nearly 5,000 couples, there was a huge reduction in the acquisition of HIV. So a 2/3 or a 3/4 reduction in the incidence of HIV in people taking the active drug rather than placebo. Similarly, we've heard already, it was mentioned, the Rakai study, but I chose to show the first of the circumcision trials, which again came from South Africa, from Orange Farm, that the people who were circumcised, the men, HIV-negative men who were circumcised, were much less likely over the next 2 years, and the effect has actually been shown to continue, much less likely to acquire HIV. So science conducted in Africa has given us a whole range of different interventions that have allowed us to turn the tide on HIV, as we were asked to do by the Millennium Development Goals, and we should celebrate that. And we now have a big range of proven, effective ways to prevent HIV, many of which arise from African science projects. Even more excitingly, well, no, I don't think it can be more exciting than that, actually. Equally exciting are the studies that show that giving antiretrovirals earlier in the course of infection definitely brings a benefit. So the Insight Start study that Pontiano mentioned, which had Uganda as one of the sites, and then Temprano, the study from Côte d'Ivoire in West Africa. And what this showed was that people were given either antiretrovirals at the recommendation of waiting until their CD4 count had fallen, or they were given more immediate antiretrovirals, whatever their CD4 count. So starting as soon as somebody was diagnosed, and they were also given isoniazid preventive therapy, either yes or no, as we mentioned in my very first slides, in a factorial design. And you can see that if you got no isoniazid and you deferred antiretrovirals, that you rapidly had severe adverse events, either death or severe illnesses, whereas if you had antiretroviral treatment, there was a significant reduction in those severe events, and indeed if you had isoniazid, either on its own or combined with antiretrovirals, you got significant benefit. So we could see in this individually randomized study that both strategies, giving isoniazid preventive therapy or giving antiretrovirals, or both, when people are diagnosed with HIV, is clearly and strongly beneficial. And these sorts of studies, but in particular the ones I've showed you, fed directly into the recommendations that WHO released last month, which they released early because they considered them to have such important public health impact. And they'll release the full guidelines at ICASA in Harare coming up, but they released these last month to give us all a push. And they say that any adult, and indeed it's also true for adolescents, when diagnosed with HIV, should straight away be initiated on antiretrovirals, regardless of their CD4 count. And they also say that pre-exposure prophylaxis, so antiretrovirals containing tenofovir, should be offered as an additional prevention choice for people who are at substantial risk of HIV. So like we heard of the fishing villages where 6% of people are getting HIV each year, you could stop that by offering those people, if you could find ways of delivering it and to take it, you could stop that HIV infection in populations at high risk of HIV. This has also, of course, been achieved, the impacts we've had, because there's been a massive scaling up of funding, which we're aware of, and the good news is that that scale up in funding is both for the international funders in green, but very importantly for domestic funding. And domestic investment in HIV has gone up enormously over the Millennium Development Goal period, particularly for the BRICS and upper middle income countries, somewhat for the lower middle income countries, and then the low income countries, of course, it's much harder to scale up the investment. But we know now that many of the people living with HIV are actually living in middle-income countries. There are more poor people living in middle-income countries than there are living in low-income countries. The world's economy is shifting and changing, and so it's encouraging to see countries like South Africa and Botswana, who have huge HIV epidemics, taking on a big share of the funding of the HIV response. So we move, and we've heard a lot about the Sustainable Development Goals. And again, some would say that we're already setting ourselves up to fail, but we believe that that's not the case, and that history has shown us that actually HIV is making enormous progress, and we're not now trying to reverse the trends. We're trying by 2030 to end the epidemic of AIDS, and many other things as well. And I'd like just to show you some of the challenges and tell you how we're going to get there. We know that now that we have the new WHO guidelines, less than half the people who actually need to be on antiretrovirals are taking them. So we may think we've achieved a lot, getting 15 million people on treatment, but we actually have 35 million people living with HIV, and they should all be on antiretrovirals in a perfect world. So that's a big challenge for us. And part of the challenge comes because many people do not know their HIV status. So many of those people living with HIV don't know that they're living with HIV, and changing the way that we provide and offer testing, normalizing HIV testing, encouraging other people to be able to do HIV testing apart from doctors or nurses, encouraging even self-testing. These are all approaches that may increase the number of people who know that they're living with HIV, who should now be benefiting from antiretroviral therapy. UNAIDS has been doing mathematical modeling, which highlights the urgency, because if we don't get on top of HIV now, it's likely to resurge. So this is, again, somewhat like the Ebola story that we've been hearing. We have an opportunity at the moment to push HIV down, to get it so that it is no longer a public health problem. And the modelling suggests that the next 5 years are crucial up to 2020, and that if we can make a significant approach now, then by 2030, we really will have reduced HIV to something that is no longer a massive public health problem. And the investments that are needed for this approach, the so-called fast-track approach, are first of all the HIV treatment goal, to get 90% of people living with HIV to know their status, 90% of those who are HIV positive to be on treatment, and 90% of those who are on treatment to have a suppressed viral load. We can reduce HIV infections to 75% of the current level by putting in place the prevention approaches, including now the scale-up of pre-exposure prophylaxis for those at substantial risk. We can continue to eliminate mother-to-child transmission, which we've already made good progress on, but we have to keep pushing forward with that. And finally, I always want to come back to the importance of the obstacles to HIV, and the obstacles to HIV, but also one of the things that HIV has taught us, and really taught us well, which is that we need to involve community. We need to involve all people living with HIV, and in order to do that, we have to get rid of intolerant laws, we have to get rid of discrimination, we have to have access to justice for people, because if we don't, we can be quite sure that HIV will resurge and we won't be able to end it. So I think my summary slide and my sort of observations actually mirrors a lot of what we've heard already. We've learned that there's lots of good science going on in Africa with lots of African studies. I've put in brackets African leads because I think that we are maturing, and it's been great to see some of the centres really having African leads to that research, whereas in others, as we've heard, I see many of the first authors who still have names that don't look very African to me, and we don't, we want to make that an equal partnership whereby the African research sites are able to be at the fronts and the African researchers at the heads of the papers. There are already strong African research centres all over Africa in each of the regions, and they need continuing support. This is specifically for HIV. I've given you examples of studies that have come out of all the regions of sub-Saharan Africa. I haven't been focusing on the North African region. I think we've heard, but I'd like to re-emphasize that if we want researchers to remain researchers, they need to have careers. I very much enjoyed, Ahmed, your presentation of thinking through the engineering flows, because I think we have to think not only of funding research, but of how research careers can be built. When we heard from Rose about people simply having to go back and teach in universities, a very important job. But we need to have protected space for research within universities to allow research careers to flourish if we think that we're going to make progress. We've also heard that research covers the entire spectrum, from new drug discovery and new molecule discovery and biomedical research, through the epidemiological, through the social, through the operational. Different centres will build different parts of those research. We hope there'll be interdisciplinary spread. We talk about the no-do gap, and much of that is operational and implementational. And actually, we don't need anything new. We can achieve a huge amount with what we've already got. Nonetheless, I think it would be a big mistake if Africa rejected or didn't embrace the possibilities for exciting biotechnology and biomedical research, because that's good for development as a whole and for building economies. So I think there are different reasons, but we need to focus our reasons for different sorts of research capacity. Where will the research be done? The research I've shown you, some of it's from medical schools, some of it's from governmental research organizations. We've seen the example of UVRI, KEMRI, parastatals, and some is from independent organizations or independent research NGOs, which are trying to offer an alternative career path, partly as a result of the difficult career paths in many African universities for people who want to do research. We've heard the importance of partnership, collaboration, and networks, and we hope that the center of gravity of those will gradually move more and more to Africa. So I'm looking forward to Kevin Marsh's talk tomorrow on moving that center of gravity. Finally, I wanted to leave you with Mr. Pensillo. He was a research subject in one of our large studies just outside Lusaka in Zambia. And I like this photograph of him because he always looks to me as though he's sort of questioning me a bit. He looks a little bit skeptical as to whether we researchers are actually offering very much to him or indeed to his extended family and dependents. And I think that we have to be driven by the fact that in the end, that's what we're trying to do. And I think this comes back to mirror some of the other talks. So with that, I'd like just to thank the various people at UNAIDS, at the London School, at the University of Zambia, who've contributed to my thinking around these areas, and look forward to the discussion for the rest of today and tomorrow. Thanks.